welcome to A&R. Our first presenter is going to be Brenda Williams. She's going to do our STEMI report, so she has to stand right here.
Good morning. I'm Brenda Williams. I'm the nursing care manager of pre and post cath lab and CMT or heart rhythm analysis. I'm also a chest pain coordinator. We'll get started with a STEMI run. So this EMS run started at 13:03. They received the call. 49-year-old male complaining of chest pain and vomiting. By 13:06, they arrived to the patient. The patient was laying on the back of a pickup truck, pale with dry heaves. He was complaining of pain across the center of his chest with extension to the bilateral jaw. He was rating his pain as a 10 out of 10. He reported to EMS that he takes no medications. He had no allergies, no significant medical history. He did admit to being a smoker. 13:09, vital signs were obtained. 163 over 101, heart rate of 89, respirations 18, 99% on room air. By 13:11, they got the 12 lead, showed ST depression in leads 1, AVL, and V2, and showed ST elevation in leads 2, 3, AVFs, V3, and V4. They transmitted this to Union Hospital. They got an IV 20 gauge and a left AC. They gave him 4 81 milligram baby aspirin, chewable. The 2 sublingual nitro were given to improve his pain from a 10 out of 10 to 2 out of 10. He was given Zofran, 4 milligrams for his nausea, which was improved. By 13:22, vital signs were obtained again, getting a blood pressure of 150 over 92, heart rate of 90, respirations of 22. He was 99% on room air. His pain's starting to increase again a little bit, rating it a 4 out of 10. By 13:35, his pain and ST elevation was returning during the transport. They put a 1-inch nitro paste to the left anterior chest with no improvement. His vital signs were up again. He has 165 over 124, heart rate of 102, respirations of 27, and he's 97% on room air. By 13:37, there was arrival to Union Hospital into trauma 2. By 14:26, they got the balloon across the lesion. They put in a drug-eluting stent to right coronary artery, reducing from 100% to 0%. Patient discharged 2 days later with medical therapy to treat mild to moderate cardiovascular disease to left vascular system. He was encouraged to stop smoking and given education. Pre-hospital EKG to balloon time was 75 minutes. And door to balloon was 49 minutes. And summary so far for the year, we're at 100% for our door to balloon time being within 90 minutes of hospital arrival, which is pretty darn good. Thank you very much. You're welcome.
Thanks, Brenda, very much. Next will be Jackie Martin to do our trauma report.
So I'm allowed now, so I'm going to slide this down a little bit so you can kind of hear me. Okay. So first of all, I want to introduce Polly, who's way in the back there. Polly is our new trauma care coordinator. So Tara went back to the ER, for those of you that didn't know that. And so Polly's going to be the one that's going to work with us, and you may see her name on some things that pop up on emails and such. Misty's hanging out up here in the front. She's our registrar. We happen to have our whole team here. Dr. Lynch is here with us as well. So this is a perfect opportunity. So I am going to review a case, but before I do, I wanted to kind of show you a few things. So I'm still getting a lot of questions about, we don't know what you can do. And so I totally respect that when you're out there in the field, you're like, I don't know if Union can handle this. I don't know whether or not I should go. So I wanted to show you who we are, and I wanted to kind of talk a little bit about your CDC algorithm and how it works. You don't have to decide what level of trauma it is when it gets here as far as activation. That's our job, okay? You just have to tell us you have a trauma. So we're going to talk a little bit about that. So I've handed you the pamphlet, which is where these slides actually come from. That way you've got a resource. Okay, please don't hesitate to get a hold of one of us. We are here Monday through Friday, 8 to 4:30. My phone is on that card on the front. You can page, you can text, you can call, you can email. We will try and get an answer for you even if we don't have it. So this currently is our medical team, and this is the status will be correct for about 30 days because we're going to add another one. But we have Dr. Pusha on the left, and some of these faces you may know from the community because these guys, one, they're from the community. And two, they've been surgeons here forever. They've well established in our community. So we have Dr. Pusha on the left. Next to him is Dr. Lukey. Dr. Mark Lynch is there in the middle. He's from a medical He reviews all of our cases. When you guys bring trauma patients to us, at some point, across his desk. Next to him is Brandon Lynch, and then next here on the end is Dr. Rebecca Lynch Clark. We're adding a new one. It is another Lynch. Nicholas Lynch will be here next month. Okay, so that is your trauma medical team. Those are the doctors in the trauma room, all over one. Okay, you don't have to make that decision. All you have to do is have a trauma patient coming in the door, and based on the information you give us, we're going to make the decision at the door. So level 1, you're going to get one of these doctors. Okay, 24/7. One of these guys is on call. Okay, they're here. They have to be here within 30 minutes of the call. All right, there's Dr. Mark Lynch. There's a little bit about his education. He runs the show for us. So he is a very good resource if you have questions. Myself and always get to him. If we can't answer the question, we will go to him. This is the trauma team minus Polly because it made Monday. So Kelly Mills, some of you remember Kelly. She's been around for a while. She's actually the director. She's the director of all things emergency. So she's over the EMS, so Barry works closely with her. She's over the ED, so those managers work with her. And she's over us here at trauma. I am the trauma program manager. Misty is the registrar extraordinaire. So Misty has data at any type, any level from the inception of our trauma program. So she has a software that she can manipulate into whatever we need her to manipulate to. So we have to be verified, which is a fancy way of kind of like a certification. You guys can hear too. So we fall under the American College of Surgeons. And so here are the things that absolutely have to be in place for us to be level 3. Okay, we have to have a trauma surgeon. We got that. That trauma surgeon has to arrive within 30 minutes of the highest level of alert. We got that. They're coming from their homes. Neurosurgery is not required but recommended. Okay. Orthopedic is required. They have to be on call. They have to have a backup call. The surgeon has to be available 24/7 in case they go to another facility. We have to have internal medicine. Okay. They have to be here 24/7. And we have to have anesthesia, which has to be available within 30 minutes. Those are the things that American College of Surgeons says. If you want to be a level 3, you got to do this. Okay. Here is the things that we can do. So our surgeons have an average response time of 10 minutes. So the minute you tell us that you have a trauma, we decided that it's level 1 trauma, pages go out, and they actually physically come to the ER. Many times they're standing in the right. Okay. Trauma surgeons do rotate call, so that's never a hindrance. So if something happens and surgeon 1 can't get here, surgeon 2 is going to show up. Okay. All Union Health trauma surgeons are required to complete continuing education. So they learn every day, just like you and I have to have. They do it too. We have 2 neurosurgeons that rotate call that are specific for trauma. So they do other things too, but they rotate specific call to trauma, so they're available to us. Orthopedic, we have a very robust ortho group, and they are here 24/7. And then internal medicine as well. They're actually in-house. We actually have internal medicine here all the time. We have hand, we have ENT, we have cardiothoracic, we have ophthalmology, dental, OBGYN. Really cool about OBGYN, we have a level 3 NICU. You may have known that. You may have had kids in the NICU. So if we have an OB patient that is 20 weeks or greater and they're in a trauma, so not only will the NICU team show up, so those nurses that take care of those babies that are less than a pound, but will be hospitals. So that's an added bonus. They're literally around the corner from the ER. Those of you that know that. We have the hospitalists, which are here 24/7. Their offices are actually in the ER and the NICU and the PEDS, and then family medicine, and we have an intensive critical care. So we can do quite a bit here. Anesthesia is here 24, available 24/7. Physically in-house, 16 out of those 24 hours, and then they're on call the other 8. We have an MRI that is open and ready to go 24/7. We have a dedicated orthopedics and neuro unit, ortho neuro euro is what it used to be called. We have an inpatient rehab that is certified, so and they qualify for inpatient rehab. They can actually rehab here. We have fast capabilities, which is an ultrasound that the doctor can do in the ER. You got a patient that you think is big belly trauma, they can do that ultrasound real quick and go, oh, I think I see blood. And then they'll just scan or transfer or whatever we need to do. We have expanded blood bank response, easy to say. So if you call a level 1, the blood bank is standing in the trauma bay with the unit of blood ready to go. And then massive transfusion protocol, which we used actually. So we worked very, very hard to put together a program that will meet your patient's needs. So the 2011 guidelines are the most current. That's the CDC triage algorithm that you guys are all held to. Okay, held accountable to. When I started this questioning a few of you guys realized that you kind of know what's on there, but nobody really truly knows what's on there. I get it. It's the algorithm. I have to break things to learn them. So your algorithm actually says severe life-threatening injuries should go to the highest level of care. So in trauma, in the world of trauma, what is the highest level of care? We're 3. The highest level is 1. The closest level 1. Okay. But that's what your algorithm says. Should go to the highest level of care. What we're finding is that patients are getting something called a double cancer. So we're sending them to a level that's higher than us that they come and go, this is a little bit more than us, so then they send them to 1. The goal is the highest level of care. Okay? It's no secret. We'll be the first ones to tell you that you can do a whole lot more than we can. Right? So step 1 says attempt to transport to the highest level of trauma center. Again, I don't expect you to do that unless you're over there. If you're one of those agencies that's so close to there, you might want to think about that. Step 2 says attempt to transport to the highest level of care. You break down your algorithm, and I'll show it to you here in a minute. It's in your book. So step 2 tells you to those really injured patients. You're like, holy crap! Right? You really need the higher level of care. Steps 3 and 4 says attempt to transport to the trauma center. You got that. You got option to 2. Depending on where you're sitting, you can go either way, right? So steps 3 and 4 just says get them to a trauma center. And then there's a few things listed on there that says just get them to hospital. So the CDC says, and they put a lot of studies into this, several studies, that physiological and anatomical criteria only get you about 46% of your patients with an injury severity score. So injury severity score, I don't expect you to know that, but that's trauma speak. So after we know all the plays, after we know all the scores, then we go back and we have a system that will assign that injury. So obviously, the higher that score is going to be. The higher that score is going to be, the more your patient needs those higher levels of care. So if you're only looking at the anatomical and the physiological, so my patient looks like crap, they look like they're in shock, oh gosh, I have a broken leg. You're only looking at those pieces, you're only going to identify about 46% of the patients that have those really high scores. Okay? But if you add mechanism of injury to that, which most of you guys are really, really good about doing, then that boosts you up another 25%. So you're like, well, I don't see any deformities, but they're really pale. I don't like that pressure, but look at that car. It has greater than 12 inches intrusion on the passenger side. It has greater than 18 inches intrusion on the passenger side. Or it was a long extrication. Or they snapped a pole in half, but they're walking and talking. You think about those things as well, you're going to grab another 25+%. So you're going to be a little bit more accurate. Things to think about, okay? Special considerations, comorbidity factors. People, as we get older, have lots of, oh, I thought you were cold up already. Lots of things going on, right? So we know diabetics don't do well in trauma. We know that people with a cardiac history don't do well in trauma, okay? We know those things. So you got to think about those as well because they put your patient at a higher risk. That's why we have a that says over 65 on an anticoagulant, they have their head, they're going to get a level 2 no matter what. Because the chances of them having a head bleed is huge. So if you think about those comorbid conditions, you're going to grab another 17% of the people that really need to go here. Here's my personal theory. Call the cavalry. We can always call it off, okay? It's a whole lot easier to say, you know what, Brenda, I really don't need you, but thank you for coming, than to be in a room with a patient going, crap, I need help, okay? Because we've all said it, right? I need some help in here, or I need some help over here. It's a whole lot easier for me to look at you and go, oh, okay, that's all right. Go ahead and go back to your stations, than to get in the room and go, oh my gosh, I need help. So, risk for injury or death increases after the age of 55. I don't like this one because I'm not. Systolic pressures less than 110 might be shock if they're over 65. Okay, I wouldn't get too wound up about a systolic of 110. It's not my favorite number, but I'm like, okay, I still have control. But if they're over 65, that might be a problem. Low impact mechanisms like ground level falls might cause severe injuries. How many of you transported a patient in here that you thought, oh, that's just a fractured hip, and then we look at you later and go, oh no, man, they had a bleed. We flew them out of here. Sometimes those low mechanisms are big bad problems. Kids should always go to a ped center. We know the closest one is Indy. That's not really a possibility for us here. Anticoagulants and bleeding disorders put them at high risk when they have a head injury. They're going to deteriorate fast. We've talked about that in a couple cases in here. Burns that don't have trauma, really ideally should go to a burn center. Again, that's Indy. We get that, so we'll take care of that for you. Burns with trauma mechanisms really need to go to a trauma center. We'll take care of the trauma first and then the burns, unless you're talking airway and stuff like that. Pregnancy greater than 20 weeks. I told you we have a really awesome option here that if you bring a trauma patient in that's over 20 weeks, we're going to get an OB hospitalist and a NICU team. And then, of course, it's always your judgment. That's the part that I think a lot of you are forgetting. It is your judgment. I am not out there. I don't see your patient. I didn't see the scene. I didn't see the wreck. I didn't see the collapse. I don't know what it looked like. I like it when you bring pictures because then I get a visual perception of what happened. And I can look at that and go, oh, they walked out of that. Okay, so it's still always the EMS provider's judgment. So we have a really good integrated clinical model. We do partner with IU. We do not belong to IU, but we do partner with IU. And so we have the ability to transfer to IU Methodist, which is level 1. We have the ability to go to Riley, which is part of the IU system, and then Eskenazi, which is not part of IU, but right there geographically is the burn center. We can get you there. We can make phone calls to IU. We can make phone calls to IU. We'll find a way to get them there in a timely manner. If you think your patient's beyond us, think about a seat flight. Yes? Yes. Okay. So you still have that option. I know you used to. I've seen them land at Kroger. I've seen them land at the high school. It's definitely rural. So Julie and those guys live and die off of the scene flights. So if you think they're beyond us, don't hesitate to get them out of here. Okay? Do not hesitate to get them to those level 1s where they need to go. 6% of EMS providers fail to appropriately triage a patient to a level 1. Now, our situation's a little bit different because geographically you're too far from the 1, okay? You don't have that option within driving distance. We get that. But think about it. Don't blow it off. Think about it. So this, I know it's hard to see. So these are actual patients that one of you have brought in here, okay? And so this on the right is that severity score, that ISS. Remember, the higher the number, the worse your patient is. So the first one says a fractured right pubis and a displaced fracture of the right femur. Well, that sounds pretty bad to me because femurs bleed and there's a lot of issues that go on with that. It got a 9, okay? We keep 9s. We don't usually shift 9s. The second one says right-sided temporal bone fracture. Can't say it. Small right occipital abrasion. They got a 17, okay? Pulled these right out of our registry. The nasal bone fracture and a 5-centimeter laceration on the nose. It was superficial. It's probably bronchitis. When they broke the nose, they got it too. Multiple rib fractures, total of 5. Fractures the upper third sternum. I remember this one now. Left distal radial fracture, angulated. Dislocated left distal ulnar and a right pulmonary contusion. They only got a 13. Grade 3 splenic black with a subcapsular hematoma. Over 50%, multiple left-sided rib fractures, 5 to 11 were all broke. They got an 18, okay? And the last one says a right open shaft fracture, major right lower leg lack with foreign body, and they got a 13. So lots of things go into these. I cannot stand here and tell you the formula. She might be able to, but I cannot, okay? I know we look at lots of things like how were they injured, where were they injured, how long were they down, you know, the final diagnosis, things like that, okay? So lots and lots and lots of things go into that. So that's just hopefully a little bit clearer version of what we can do. So like I said, I was getting a lot of questions about, you guys are out there going, I don't know whether I can bring this to you. If in doubt, bring it. We'll figure it out. That is not your job, okay? I promise you, we will not hopefully berate you. And if that happens, please tell us. It is not your job to figure it out. It's not your job to figure out if it's 1 or 2. That's us. We review 100% of the trauma charts across our path. Any questions about what we can do, what's available, how it works? Did it make it a little clearer? A couple of the faces that have asked me are in this room. Did it make it any clearer about what we can do? About the only thing we really cannot take care of is a big facial fracture injury. So if you get a big bar fight or somebody that smacked a dash or something, almost always we will ship those on. Yep. Yes. Some of you have long response times. We get that. We love that you call us because then we've got 15 minutes to get the team ready. So, all right. If you have questions, please reach out. Please reach out. Use your references. Okay. Remember that comorbidities make it worse. Mechanisms of injury make it worse. All right. I do want to review one case. Okay. It's a PEDS case. So this was a pediatric trauma. It was an MVC. So the 911 call came in at 15:53. Not that one. I can't do that one. 911 call came in at 15:53. They were so obviously they were en route at 15:55, so that's pretty good. On scene at 59, so it must not have been too far from where they were dispatched. And then they left scene at 16:11 and got here at 16:21. So in the afternoon, this did happen over the summer. So scene time was about 14 minutes. So the call to getting them in the ED was. So this was a 4-year-old little guy that was in an MVC. So when the squad got there, he was sitting on the edge of the grass, edge of the road, and they had bruises over his right eye. He had abrasions to his lower abdomen, and it actually says from the vehicle seatbelt. The engine personnel, so the truck guy said that they found him in the rear. It was the rear behind the driver, I think. And he was in a booster seat. He never lost consciousness. This is a 4-year-old. How would we expect a 4-year-old to respond to you guys on scene? They just got in a crash. His grandma was driving. Okay. He's in his booster, and then you big bird. So how would we expect this kid to react? Calm. Yeah, scared. Maybe crying. Where a little boy thinks no, I mean. Normal for 4, right? He was in a booster seat. So the assessment says that his eyes appear to be reacting, but they're slower than what should be normal. So the medic says, I'm not really sure what he should do because he's 4, but I know this is not right. Okay? And so the patient keeps trying to lay down and go to sleep, and the medic keeps telling him, nobody, you have to stay awake. Nope, you can't take a nap right now. So the patient told the medic that he didn't feel like he could stand up on his own. Okay? Not 24-year-olds going to say that. Now they note that there's bruising over the laceration from the seat, which they called it an abrasion before. That's the only description they can find in this run sheet. They've called it an abrasion to the abdomen, and now they're calling it a laceration. I think this is a mistype, but when you look at the record, it does not match. And the patient's grandma was driving, and she actually requested Union, and so the medic just carried him. So on the way, he continues to be lethargic, and now they're saying he's pale and his belly bruising is getting worse. So it hurts when they palpate it. They did do it, put him on a monitor, he's sinus. They tried an IV, but he's 4, and I don't know about you. They did call a trauma alert, and they said that he declined slightly in transit. So not hugely declined, but did decline in transit. So I have preached this since I started doing trauma review. What's his vital signs? He is 4. What should his pressure be? As 2 times the age plus 70, what should his pressure be? He's 4. What do I want that systolic to be around? 78. Okay, remember that. So he's 98/60. His heart rate's about 120. That doesn't freak me out. He's 4 years old. He was just in a wreck. He's sat in 99%. I'm okay with that. His class 15. He just wants to. So they tell us that he's an MVA, about 30 mile an hour. He does not have any loss of consciousness. He's lethargic. They call for a trauma alert. We put him in PEDS trauma. He gets in the ED at 1826. We actually call him 11. Okay? So he's Calvary. We do a CT of his abdomen, and he has a grade 3 to grade 4 laceration to the lower third of his left kidney. Yeah. Okay? There's no extravasation, which means there's no fluid forced out of that kidney. There's no blood or urine floating around where it's not supposed to be. He does have a hematoma, retroperitoneal. Remember, that's behind. Okay? And it's large, but it's not extravagating, so it's not pushing blood anywhere it's not supposed to. We do CT his head. And he has a small soft tissue contusion over the upper rim of his right orbit, which makes sense. We do a C-spine, it's negative. We do a chest x-ray, and it's negative. So what is the big rule with kids? What happens with kids when they're injured? Remember? They compensate, crash. He's pale. He's lethargic. He wants to go to sleep. We now know that he's got a laceration to his kidney. Okay? He was in a booster seat. He was secured. He was in the back seat. So the ER doc says that the vehicle was struck by a bus that failed to stop at a stop sign. It didn't show up in the EMS plan. Now, mechanism of injury. Remember, if you put mechanism of injury in there, it makes a whole lot more sense. You're like, oh, holy crap, now this makes more sense. 30 mile an hour is not a huge travel, but when you get struck by a bus, that makes it a little different, right? So about 30 mile an hour, airbags go off, nobody loses consciousness. The car was a 17 Chevy. I don't know if it was a school bus, a city bus, I have no idea. This is a bus. There's no past medical history. That makes sense. He's a happy, normal 4-year-old kid. He appears pale, but he's medically stable. The doc's okay with that right now. And they reported to the doc. So the medic, when he gives his report, says the kid's hypotensive. Because if you look at, where'd it go? I look at that blood pressure and I take out the fact that he's a 4-year-old little boy, I would call that hypotensive, wouldn't you? But he's not hypotensive. What is he? He's hypertensive. Okay. So we transfer him to Riley. That decision's made about 5:30, and he goes brown. So at Riley, his hemoglobin's pretty stable at 11. We're okay with that. They clear his C-spine. They admit him to trauma. They type in crossing, but they did not have to transfuse him, so they were ready, but didn't have to. He remained stable. They gave him some pain management. They did keep him in PO, and then they advanced him a little bit before he got to go home. He was on strict bed rest. Day 4, he remained hypertensive, and they actually had to give him labetalol. His nephrology come in, and they said to continue lisinopril at home for hypertension. And he was going to follow up as an outpatient. And he was actually discharged home day 5 from Riley. So what were the opportunities? Everybody is sleeping. Come on. Opportunities, kudos. First of all, kudos to the medic for saying, woo, this kid looks like crap. Let's get him out of here. Okay. Remember to make your runs match. So the abrasion versus laceration in the abdominal, that's huge. If you got a laceration to the abdomen versus an abrasion to the abdomen, you're looking a couple different pathways. But what opportunities were there? There were a few. Not a lot. It's a good run. The medic did a really good job. The kid fared well. So what were the opportunities? Yeah. And I think if I remember right, this was kind of a new, not new, but. Yeah. So was the mechanism significant? Yeah, he was tacking a little bit. Was the mechanism of injury significant? Yeah, we didn't really know that in the EMS report. I get it out of the doc's charting because grandma tells the doc, oh no, we got hit by a bus. Oh, and a Chevy Cruze, not a big car. He was behind grandma in the back seat in a booster. Yay, he was in a booster, which probably is what saved him. Okay, what else? Yeah, I think the MOI could have been a little more descriptive. I agree. And I know I've been there. I've spent time in your world, and I know not in the afternoon as much, but had that been 3 o'clock in the morning, it used to be like 2 lines, you know. I get it. So call to trauma alert. Great job on that. We gave him a level 1 and got him out of here timely. So. All right. Any questions, comments? Okay, I'm gonna turn over to Dr. Abbasi. We did not do one here. I don't know if they did one at Riley because honestly didn't look.
So Dr. Abbasi will be next, but nutrition would like to speak to you guys. They've got a couple things they would like to talk to you about. Just 2 seconds. Video. Okay.
You'll have to bear with me. I'm not used to being on video, so this is going to be fun. All right, Nutrition Services is excited to offer on-duty first responders a daily discount beginning September 1st in honor of all first responders nationwide. When you join us in uniform at our main cafeteria, you'll be able to enjoy a 20% discount. If you're interested in seeing the menu for that cafeteria in advance, you can download our Bite app because we know you guys are all always on the go. If you're going to join us in uniform at one of our coffee shops, you can get a 10% discount, and that would be for our Starbucks we have in the West Building, the 7th Street Cafe, or if anyone's working third shift, we also have our East Coffee Shop on the first floor. This before tax food and beverage discount is for first responders as our way of thanking you for the service and commitment that you have to our community.
Thank you very much. Take advantage of that if you can, if you happen to be out and about and want something to eat. So, Dr. Abbasi is next. He's do what? Oh, is he? Oh, yeah. But when Saproti's on strike, you better come eat. So, Dr. Abbasi's got his presentation. You got to stand.
Hey, good morning, everyone. Thanks for coming for this lecture. So, as you can tell, the title is back pain. Whose pain is it anyways? So, back pain is a common complaint, and it usually evokes an internal response that we all have, right? And how many of you guys, when you guys get that call, patients having severe back pain, how many of you guys get real excited? And I want to see a show of hands. And I see 0 people saying they have a show of hands. But it's interesting, right? Because most of us have at some point have had back pain, right? And guess what? It does not feel very good. Or we have family members who suffer from back pain. So we all recognize it, but why is it that when the patient has it, we just honestly naturally get really annoyed? And the focus of today's lecture is to kind of openly address the fact that we all probably get annoyed by back pain, but not all back pain is what it may appear to be. So for full disclosure, much of this content I adapted from a good friend of mine who's an EMS educator, named Dr. Glenn Burkett. So I don't want to take credit for the amazing work he did, but I did adapt much of this content from him. So why is this topic important? Because quite frankly, we see back pain quite a bit. In the emergency room, about 2.3% of all patient visits are regarding back pain. So that's 1 in 50 patients. And you guys are on the tail end of that. You guys frequently, I know, get calls for back pain. So my goal today is to talk about the differential diagnosis for back pain, and more importantly, talk about red flags, because there are patients that may complain of back pain, but it may be something very life-threatening and may be very serious. We're going to talk about some of the spinal cord syndromes, which can cause debilitating, life-altering disease for patients, and we're also going to talk about pain management. So what's my goal? So we're all trained to treat cardiac complaints in a very systematic fashion, right? You guys put the leads on, you get vital signs, you get a 12 lead. You're trained to interpret 12 leads the same way every time, right? Rate, rhythm, access, intervals. So my goal is to have a system in place so that when you get a back pain complaint, in the same way you look and treat a cardiac patient, perhaps we could treat them so we don't miss anything. And also to think readily about some of those red flags to make sure we're not missing something in an otherwise benign complaint. And the other important thing to notice is language, right? And we're all guilty of this. You guys play an extremely important role because as first responders, you can really set the tone for how a patient is interpreted in the emergency room or anywhere for that matter. So if the impression that I get on a busy shift is that this is a chronic pain seeker, it may interfere with my ability to objectively evaluate the patient. So, and we're all guilty of it. We all say things, we all write things in our notes that sometimes can be harmful to patients. Just a gentle reminder about that. So as far as definitions go, this is just some basics about back pain. Acute back pain is back pain that's been lasting less than 6 weeks. versus subacute, which is between 6 weeks and 3 months. And then there's chronic back pain, which lasts longer than 3 months. And there's a lot of different things that can cause back pain, right? Sometimes it's pretty obvious, right? Here's a guy who essentially got shot up. You can all understand why he is in pain. And sometimes it's actually not as obvious. So you might have someone coming in with back pain, and it might seem innocuous and not that concerning, but they get to the emergency room and we get a CAT and we see their aorta, their AAA is ruptured, right? That's not something you can immediately jump to when you're in the back of a truck. But it's just to kind of explain that that patient that you're seeing that's having back pain, maybe there's something more serious going on. And sometimes, indeed, you have to open them up to really get to what the issue is. And sometimes back pain can be life or limb threatening, especially when we're talking about any issues with the spinal cord. So here, this is an MRI that shows some injury to the spinal cord. And the problem with any issue or any damage to a spinal cord is it's very difficult to treat. It can cause life or limb threatening injuries. And sometimes back pain isn't all what we think it is, right? Sometimes it's just a skin issue. So herpes zoster, a lot of times an elderly patient, they don't know they have zoster. They just, gosh, my back hurts. So sometimes it's just at the surface level. So this is just to highlight, it's really important to do a skin exam. But again, like I mentioned early on, we all kind of struggle with back pain, right? Maybe because we've all had our fair share of pain seekers, they do exist. Drug addicts, they do exist. We often find ourselves labeling them. We often walk out of a room, or we often, as you guys interact with patients, think, gosh, this is such BS. And we all think about pain pills, right? I mean, when we think about back pain, we can't help but think about opiates and drugs of abuse. And you know, the certain medication starts with a D. So just as a point, the potency of Dilaudid versus hamburgers, this is kind of a nice analogy. That's how many burgers Dilaudid is, so you can kind of tell why certain patients want the D. And sometimes we just want to tell them to suck it up. But this is really important. If you find yourself frustrated by a back pain patient, it might be time to take a step back. It might be time to slow down and think about what's going on, because it's very easy to lose your objectivity, and it's very easy to miss a life-threatening diagnosis and make a medical error. Because here's the problem. There's something called diagnosis momentum. Does anyone here know what diagnosis momentum is? Have you guys heard that term? So diagnosis momentum is basically provider number one labels someone with a diagnosis. And then every subsequent provider they see assumes that is the truth about that patient. And that diagnosis, whether it was correct or not, follows that patient forever. And it's something that, unfortunately, a good portion of patients are stuck with, right? So it's something that we want to be really, really careful about, because it's possible that the patient may be crazy, annoying, and seeking drugs, but it's also possible that they may have a real disease. So it's really important to maintain our objectivity. And as EMS providers, you guys set the tone. You guys are the first point of contact. So when you guys come to us and say, Doc, I'm worried about this patient, you'll notice we immediately get concerned, because you guys know, you guys were in the truck, you guys saw what you saw, you were in the scene, we were not there. And unfortunately, if you guys aren't as concerned, then we aren't as concerned either. So you guys have a huge role when you see patients in general, and in particular when you see patients with back pain. So I know that when I'm on a really busy shift, you know, it's easy to take everyone's word for it. And there's nothing wrong with that. We have to trust each other, but we also don't want to take any liability, right, in making a bad decision for a patient. So just always remember your exam and your critical thinking when you see these patients is going to be key. So here's a quick differential diagnosis. So these are some of the emergent causes of back pain. Some of them seem obvious, some may not. One is obviously an aortic dissection. One is cauda equina syndrome. And if you guys are not familiar with any of these, you can raise your hand, I'll explain what they are. Or I can volunteer Dr. Mark Lynch to explain what they are. Epidural abscesses or hematomas, meningitis, ruptured or expanding aortic aneurysms, or spinal fractures, or subluxation of the cords, or any kind of root impingement. So these are emergent, time-sensitive causes of back pain. Here are some of the more urgent, meaning they don't need emergent surgery, but they should be urgently diagnosed. Any back pain with a neurological deficit is always going to be concerning. Any herniated disc that's going to cause neurological compromise, malignancy, sciatica where you actually have motor nerve compression, any spinal fracture, spinal stenosis, transverse myelitis, or vertebral osteomyelitis. And then these are some of the more common but stable diagnoses. Any kind of ligamentous injury, muscle strain, ankylosing spondylitis, DJD or degenerative joint disease, herpes zoster, or more commonly known as shingles, disc disease, any pathological fracture, arthritis, and spondylolisthesis. It's also important to know that there are other pathologies that can refer pain to your back. Cholecystitis, esophageal disease. I won't go through this whole list, but the point of the matter is that patient, no matter which of these disease processes they have, may just give you a benign complaint of my back is hurting, and we don't know which one of these grenades is hiding in their body. So this is the most important slide I'm going to show you guys. If there's anything, if you're sleepy, if you worked overnight like I did, and you want to wake up, this is the one slide I want everyone to know about. And these are the red flags for back pain. So if you see a patient and you see any of these, it's a trigger to raise your antenna. So trauma, right? That's pretty obvious. People fall, things can break, never a good thing. Age greater than 70 or mild trauma in age greater than 50. Why? Because starting at age 50 and more particularly age 70, you're more susceptible to things breaking when you fall. I'm sure every single person in this room has taken care of a patient. The call was back pain and you get in and there's a hip fracture, right? Prolonged steroids or immunocompromised patients. Anyone know why prolonged steroids might be an issue? So steroids for too long causes osteoporosis, which causes weakening of the bones. So there are some patients that are on chronic steroids for like lung disease and other issues. They can have back issues. What about like immunocompromise? Any idea? So someone that has a suppressed immune system, they're more common, they're more at risk for developing an infection in their back. So any kind of infectious process. So back pain and fever is a huge red flag. That could again be a sign that they have an abscess or some kind of infection. Syncope and back pain is super concerning because you don't know, is that aorta okay? Did something happen with their aorta or any of their internal organs? Sudden onset, like someone, for example, that never gets back pain and they have back pain while they're resting or there was no trauma, that's always going to be of concern. A history of cancer, night pain, meaning their pain is worse at night, or they've had weight loss or night sweats, that's concerning for a really bad process such as metastatic disease or an abscess. Any kind of recent infection. IV drug abuse, these patients unfortunately are the most frequently missed because we all chalk them up to just drug use and pain seeking, but they can get real disease we'll talk more about that in this lecture. Any unexplained pain in pediatric patients. Kids, by rule, should not have back pain. A 5-year-old should not have back pain. So if you get a call because a 5-year-old is not walking, that is a huge red flag. And anyone with any indwelling catheter or hardware, just because these are at risk for infection. So these are red flags that you got to look for. So when you examine these patients, right, so you got them in your truck, you want to do a nice exam the way you're taught to do. These are some of the things you want to pay attention to. Do they have abnormal vital signs, right? Vitals are vital. So are they hypotense? Could it be a ruptured aortic dissection? Sorry, ruptured aortic aneurysm. Are they hypertense, which could be an aortic dissection? Are they tachycardic, which can go with either of those? Do they have a fever, which could go with some kind of an infection? Do they have a pulse deficits or unequal blood pressure in extremities? Does anyone know what that alludes to? Why would someone have different blood pressures in their extremities? Someone speak loud. So if you have a dissecting aortic aneurysm, you can get pulse differentials, and that's a pretty easy test to do, pretty benign in the back of a truck. So I would say if someone's hypertense, you check the blood pressure in one arm, it's sky high, and then you're like, let me just check in the other arm, make sure that's correct. Wait a minute, why is it so different? That's a huge red flag. Urinary retention or incontinence. Anyone know why that might be an issue? Oh, good. What else? Good. I'm also thinking of cauda equina, which is an issue with your spinal cord. Any focal weakness, numbness, or tingling. If a patient's complaining of that, or they have like some kind of a motor deficit, that could signal that there's an issue with their spinal cord. Any kind of a new murmur, anyone know why that would be a concern? That again could point to something with the aorta or something like an endocarditis. And a pulsatile abdominal mass, which is extremely rare. Anyone know why? That one. When would you have a pulsatile abdominal mass? Exactly. An abdominal aortic aneurysm. So we're all adults in the room and we're all adult learners. So I'm going to go through some cases and I'm going to take our time and we're all going to kind of think through it. No judgment here. We're all just trying to learn and make ourselves better providers. So just to make this simple and straightforward and not overcomplicated, we're going to assume that the scene is safe for all of these runs. All right. So here's case one. The dispatch calls 5 Charlie 3. Patient had some fainting. The patient's alert, and the patient does not have difficulty breathing. All right. So that's the first case. So you get on scene. You see a 61-year-old male, and this gentleman is having back pain. So here are the vital signs. You see a heart rate of 97, a blood pressure of 182/94, a pulse ox of 97% on Lemaire, a respiratory rate of 22, and a temperature of 97.3. So remember, vitals are vital. So just looking at that, can anyone tell me what might be of concern to them? Exactly. So some relative tachycardia, he's hypertension, and maybe a little tachypneic too, right? That respiratory rate is 22. So you do a good primary survey. There's no massive hemorrhage. The airway is patent. The respiratory rate and depth are adequate, and both breath sounds are appreciated on both sides. From a cardiac standpoint, you see good palpable radial pulses. From a disability standpoint, GCS is 15, they're neuro intact. You expose the patient, there's no obvious trauma, and their finger stick is 116. Does anyone see anything so far? It's kind of worrisome at all, right? Did a good primary survey. You get a quick sample history. So the patient was having sudden onset back pain while watching TV. So thinking back to our red flags, we talked a little bit about that. Sudden onset pain at rest, that's a red flag. They have no allergies. They're on metoprolol, amlodipine, and simvastatin. They have a history of hypertension, hyperlipidemia, and prediabetes. They had coffee this morning. They smoked a cigarette. And there's nothing much. Does anyone have any initial thoughts, things they're thinking about when they hear this story?
Cardiac response.
Absolutely. That is a key point that you said. So someone can be very textbook about it and say, well, he's not tachycardic, his heart rate's under 100, but you pointed it out, they're on a beta blocker. So we're technically masking any kind of tachycardia. Anything else anyone see concerning so far?
The prediabetes, possibly atypical chest pain.
Yep,
Go out there, but
sure. So we got a smoker with hypertension, hyperlipidemia, and diabetes. So it sounds like a lot of vascular risks, right? So you proceed, you do a secondary survey, and the patient says, you know, they got numbness and tingling in their right leg. They're real sweaty, and then you do a good pulse exam, and you notice, you know, that leg that's tingling, you know, the pulse is a little bit diminished compared to the other leg. Now, what can you guys think of that could possibly put all this together? I got to vote for an aneurysm. DVT. What other votes do we have? Okay, what else we got? So let's review all the red flags. Syncope, abnormal vital signs, hypertension we talked about, the suddenness of the pain, there was no trauma, and now we have a focal finding. We went through a differential, but these are the two that really come to mind as an aortic dissection and a AAA, but what's the differentiator between the two? In the vital signs, there's a key discriminator between the two. Perfect. In an aortic dissection, your blood pressure ramps up because you're trying to get blood through the true lumen. Whereas in a AAA, especially one that ruptures, you're actually losing blood. So you're going to be hypotense. And have you any guys seen an aortic dissection? You guys have seen it? So it's a tricky diagnosis, and unfortunately, you know, it gets missed in the emergency room. And, you know, patients, some of the other symptoms they may have is stroke-like symptoms. And, you know, I've seen it where a patient comes in like a stroke, and it's scary because they actually have not a stroke, they actually have a dissection. Chest pain alone can be the only complaint a patient has that can point to an aortic dissection, and they can also complain of a headache. If you're ever worried about an aorta, you can always do an abdominal exam, but I will forewarn you, it's very rare to find someone with an actual pulsatile mass. It's in our textbooks, and we'll take our board exams and it'll show up, but in real life, I've never seen it. I'm sure Dr. Lynch has seen it a handful of times, but I can't say I've ever seen it. So again, just a quick review. The blood pressure would be high for a dissection and low for a AAA rupture. The blood pressure discrepancy, although it's a pretty good sign that the patient has an issue with their aorta, it's only present, it's not very common, it's only 30% sensitive. So just because someone doesn't have it, doesn't mean they're out of the woodwork. You can't use it to rule out. You can frequently get a pulse deficit like this patient had between the affected extremities. They can have stroke mimics, and about a third of these patients will have a new murmur. So what exactly is happening in an aortic dissection? Basically, your aorta is made up of different layers of tissue, and typically the type of patient that ends up with an aortic dissection is someone with uncontrolled hypertension. So what ends up happening is the walls of the aorta become very weak from the constant pressure, that blood pressure being so high, that you actually get a tear in the intima and you get what's called the true lumen and you get the false lumen. And as you continue to dissect, your pressure actually goes up because you're still trying to get more blood through the true lumen. And this becomes a real issue because your overall perfusion isn't where it needs to be. And so it's totally life-threatening injury, and the dissection gets worse. You can also start dissecting in your coronary arteries. You can have a massive pericardial tamponade, and you can die pretty quick. And if you've ever seen one, you know you never forget these. That's versus AAA, which the biggest risk factor is smoking. That's why they recommend adult males after the age of 50 with any smoking history get routine screening. This is where you actually develop a thickening of the wall. But like anything else, like a balloon, if you blow a balloon with too much air, it's going to pop and burst. Well, the aorta is just as susceptible. If the wall gets too dilated, eventually it can burst, and that's not a good thing. So what do you do in the pre-hospital? Let's say you're suspicious about any issue with the aorta. You're going to want to do what you've always been taught, get good vascular access with large bore IVs, and you really want to give pain control, especially with the dissections, because the patients are under a lot of stress. They're releasing a lot of catecholamines, and you want to decrease that by giving them appropriate pain control. And you want to transfer them to a place that's capable of dealing with it. And here we can. We are able, we have cardiovascular surgeons that are available. So you don't want to take them to, for example, Clinton, if you're highly suspicious. No one's going to be able to help you there. So anyone have any questions about aortas? All right. So we'll go to another case. This is case number 2. So 5-alpha-2 calls and says they have a patient, they're not having any difficulty breathing, they're completely alert, they didn't faint. And it's a 22-year-old female with back pain. So again, this is the exact patient that we all groan and moan. Oh, she's only 22. She's having back pain. Oh my God. So here are the vital signs. We got a heart rate of 108. We got a blood pressure of 146/82, a pulse ox of 99%, a respiratory rate of 22, and a temperature of 101.2. So who wants to dissect this, no pun intended, who wants to evaluate these vital signs and kind of go through what they might be concerned about? Absolutely. Kaki Takipnik Fabral, 22-year-old female. So you do a primary survey, right? No massive hemorrhage. The airway is patent. Breath sounds are good. Cardiovascular, the circulatory exam is good. The neuro exam is good. You expose the patient, no trauma, and the finger sticks, once again, 116. So you do sample history. So she's had back pain for 3 days, but it's worse than it normally is. She's allergic to sulfa drugs and penicillins. She takes Suboxone. No other real past medical history. Her symptoms started last night. She had dinner last night, and she's been feeling, chills and fatigue. So you do a secondary survey, and you percuss over the spine, and you notice that her tenderness is from the region of T8 to L3. There are no step-offs, and there are no deformities. So does anyone see any red flags you might want to worry about right now? Fever, what else? So how did you figure out they're a previous drug user? Suboxone, excellent. What? So right, fever, IV drug abuse, and abnormal vital signs. So what do you guys think could be causing her back pain? Okay, so osteomyelitis, an abscess, meningitis, what else? I'm sorry? You said PID? So we have a lot of good differentials here. So discitis, osteo, spinal epidural abscess. Again, things can refer. So pneumonia, pyelonephritis, cholecystitis, could be a lot of different things, right? But unfortunately, in this patient, we have some serious issues because she does IV drugs. And so this is kind of like the only way to really diagnose this stuff is MRI. There's limits to our physical exams and any other. You know, osteomyelitis is injury, actual. The problem with epidural abscess, as you can see here, it can encroach on the spinal cord and cause significant injury and motor deficits that start to encroach on them. You can also get like discitis, which is actually the disc between the vertebrae can get infected. And again, the main issue with all of these is your spinal column, your spinal cord is all there, and you don't want to cause any sort of injury to that. And the usual pattern here is things can start as simple discitis and then progress to osteomyelitis, and then obviously you can have an abscess. So again, this is a patient that I think we're all guilty that we can easily label, oh, it's just a silly drug user. Oh, she's only 22. Oh, she's so full of drama. And yeah, we can cause major disability to this person. So in the pre-hospital setting, I mean, this patient easily is serves positive, so they should flag your attention for sepsis. They easily deserve IV fluids. They deserve antipyretics, and of course, they deserve pain control. So here's the trickiest part about these patients, and this is an open forum for you guys to even talk about strategies that you've dealt with. But in this patient, we all know with their history of drug abuse, with her being on Suboxone, it is really hard to control their pain when all you've got is morphine or fentanyl on board. So does anyone on the room want to talk about, maybe they've had personal experience with this, or not personal, but professional experience with this, dealing with someone like this? Because inevitably the truth is you're not going to eliminate their pain, right? Anyone want to offer up suggestions or? Sure. And there's definitely a fair population that's cognizant of that, but then there's also that population that just get my pain. And the truth is we don't have a good solution to this. But again, it's setting expectations for them, letting them know that, you know, you're going to try your best to treat their pain. Sometimes it's hard, and, you know, just because they're on drugs, maybe she's born with it, maybe it's methamphetamine. But at the same time, the same population, they can have real disease, and we need to worry about it. So any question about abscesses or any of these infections you can get in your back? Excellent. All right. Another case for you guys, case number 3, 5-alpha-1. Patient didn't have any trauma, no difficulty breathing, and they're completely alert. You arrive on scene, you see a 29-year-old patient, and they're complaining. They have a history of back pain, and here are the vital signs. Does anyone see anything concerning? Yep, slightly hypertense. Anything else? Okay, good. So we do our primary survey. There's no massive hemorrhage, the airway's pain, nothing wrong with the breathing or circulation. No, but when you do your disability exam, you notice there's a little bit of weakness with hip flexion in that right lower extremity. You expose them, no trauma, and their finger stick is 116. So again, sorry? I think so. Again, weakness to hip flexion on that right. So you do your sample history, the pain's in the middle of the back, allergic to bee stings, They're on recombinant factor 8 as needed, history of hemophilia A and GERD. They ate breakfast this morning, and they started having symptoms about a week ago, and now they're feeling numbness and weakness in their legs. You could proceed to do your secondary survey. They have 5 out of 5 muscle strength in the left, but only 3 out of 5 on the right. Decreased sensation in the right, but normal in the left. And they can feel, this is backwards on the last bullet, but they're having difficult, no, this is correct. But they're having, they can feel painful stimulus in their right, but they can't in their left. So what do we make of this? What are these red flags, guys? Neurological changes. All right. Anything else anyone picked up? Hemophilia, tell me, talk to me. What's the problem with the hemophilia? They bleed, right? So you got a patient with a bleeding disorder, with a neuro complaint, with a neuro deficit. So what do we start to think about? I'm sorry? Absolutely. So like maybe a bleed in the brain, maybe it's an epidural hematoma. So there's definitely, anytime there's a patient with an extremity weakness, and we have to think about stroke, right? We're all trained. Can't move their right arm, leg, we got to think about stroke, and we frequently get tunneled into that, and frequently forced into it because we're under such a time constraint, etc. But what sometimes can get missed in the chase for that stroke is an issue with the spinal cord. So I am going to talk about some interesting things about the spinal cord, because of all the things that we miss as even physicians, all these neurological things, spinal cord related, that's what we miss. We're really good at STEMIs, we're really good at trauma, thank you, Jackie, but we're not good at spinal cord, and we're just not good at neuro. We're honestly below average. But that's why we're going to talk about it today. So this patient, again, you guys appropriately identified, they're hemophiliac, and so there's probably some issue with that, and we'll get to that in a second, what happened to this patient. But in general, any patient with a bleeding risk, you got to think about trauma, any recent procedures, especially in this area. Patients get a lot of procedures done for pain management, like epidurals. You got to think about bleeding from these procedures. And again, our population has a lot of people on Coumadin, Xarelto, Eliquis, so we got to think about spinal epidural hematomas. So basically, you're getting a certain amount of blood that's essentially compressing on your spinal cord, and that's what causes these symptoms. So the spinal cord anatomy is actually really, really interesting because it's divided into like an anterior portion and a posterior portion. And so in the posterior portion, which we'll start with, is something called your proprioceptors and your vibratory sense. So when we walk every single day, we're totally taking it for granted, the fact that we have something called proprioceptors in our posterior spinal cord that allow us to appropriately put our step and get our gait right. So if you ever see, for example, someone with Parkinson's, I mean, these patients have these wide, shuffling, arrhythmic gait. They have issues with this because their proprioceptors aren't working. So this is something that we don't always appreciate, but we have this in our spinal cord. People with vitamin deficiencies, they have issues with this. In our anterior part of our spinal cord, we have these different tracts, and the different tracts are responsible for different things. So we have tracts that are responsible for our motor activity, like when we use our muscles and do things. We have tracts that are responsible for pain. So if something's hurting us, it's coming from that part of our spinal cord. Sensing temperature. So if you guys ever notice, it doesn't take much thought when you put your hand near a hot surface, how quickly you withdraw. It's because our spinal cord is processing all this information much quicker than we can think to let us know to move our hand away. And some of the more detailed stuff about how these different tracks cross over as you go down the spinal column isn't important for this lecture, but it's important to just kind of recognize that the spinal cord has different tracks, and depending on where the spinal cord is injured, you can get a different symptom in the patient. It's the main takeaway. So there's really 5 different things that we need to know about with the spinal cord. One is a complete transection, which is basically you slice the whole spinal cord. Another one is anterior cord, where the anterior part of the spinal cord gets injured, and that's going to have different symptoms, versus central cord, which is where the central part of the cord gets injured, which is Brown Sequard, where 1/2 you get a hemisection that gets injured, and then there's cauda equina, which is a different whole other beast. But what is complete transection? You basically lose everything except your reflexes. So you lose your ability to sense things when someone touches. You lose your motor strength and all your autonomic innervation, like your sweating and whatnot, completely gone. But you can still have reflexes, because those reflexes come from peripheral nerves and spinal cord is central nerves. And the most common reason why patients would have a complete transection is usually some kind of trauma. It's more common than any other reason. And you can see neurogenic shock with that. So do you guys know what neurogenic shock is? Like, have you guys ever seen it? Like, someone want to bravely say what they think neurogenic shock is?
For your vagus,
Absolutely. That's actually a really good explanation. So you'll be hypotense, but you don't get, normally hypotense people have a reflex tachycardia, but in these patients, they have what's called a relative bradycardia, meaning they may not be bradycardic, but they're not mounting an elevated heart rate in response to the hypotension because they're in neurogenic shock. Central cord syndrome, think about an elderly patient. This is where the elderly patient, the story you'll get is the elderly patient was walking and he or she fell and their neck got extended. That injures the central part of their spinal cord, and the biggest deficit they'll have is their upper extremities feel more weak than their lower extremities. So this is really important, because I've actually seen a couple while I've been at this hospital of an elderly patient clipping their chin and they just feel like their arms are weak. If you get that story, then that, obviously I know you guys are going to put them in a cervical collar, but I think it's also important to make sure you endorse that concern with the provider, because this is a diagnosis that needs to be made with an MRI. I think we kind of talked about this. So it's for simple purposes, the central part of the spinal cord. Brown Sequard is kind of an interesting thing. This is what happens. The common scenario for this is someone gets stabbed in the flank, and the knife, what it does is it cuts into their spinal cord. And what it'll do is, if you cut half of the spinal cord, you lose your muscle strength and you lose your proprioception or your vibratory sense on that side, and you lose sensation on the opposite side. So you're probably not going to be spending a lot of time doing the physical exam on this patient because they just got penetrating trauma, but this is kind of what you would see. So it's kind of an interesting physiological finding that we lose motor strength on that side, we lose proprioception on that side, but you lose pain and temperature on the opposite side just because of how the anatomy of the spinal cord is. And then there's anterior cord, which is basically any kind of injury to the anterior part of the spinal column. And that usually happens more as a consequence iatrogenic, like usually there's some kind of a surgery done, like to the aorta, and then they have an injury there because they lose blood flow to the area. But you basically lose motor strength, pain, light, and touch below that level. So this is, again, just remember that if someone has some kind of surgery done to their aorta and they're complaining of neck pain and they're complaining that they are having trouble moving their limbs, or they're having issue with sensory, that this could be an issue that anterior part of their spinal cord. And basically what ends up happening is, like I said, some kind of procedure is done and the vascular supply to that part of the spinal cord is injured. You guys ever heard of cauda equina? Is that a new term for you guys, or do you guys ever heard that term? Not heard it? So this is something that we always have to screen for when we're in the emergency room. Basically, you get the very distal part of the spinal cord. The spinal nerve roots can get injured, and the frequent complaints are fecal incontinence or urinary retention, impotence. So if you get a patient complaining of back pain and they also tell you, I have not been able to urinate in 12 hours, I keep trying, that's usually the common complaint. And this is an emergent diagnosis that we have to make. So just always remember that they can't urinate and they're having back pain. And it's frequently caused by herniated discs, tumors, abscesses, hematomas, and trauma. So I know I went over a lot of stuff, but I want to just take a second to ask if anyone has any questions. All right. So when I was in residency, we had to do a lot of EMS runs, and I feel like I really gained a lot of appreciation for what you guys do. I've been involved in cardiac arrests at crack houses. I've seen, and I've also been a part of when you guys get appreciated. So I do want to take a second to recognize how difficult your jobs are, and I do totally know that you guys get underappreciated by your patients. You get underappreciated when you walk in the hospital. But I want you to know that we all do appreciate you guys, even though it may not be obvious. And having been in the back of the squad like you guys, I know that the challenge is, it's easy to resuscitate a patient when I have a room, I have a respiratory therapist, I have nurses, I have techs. You guys run 2 people, 3 people. Some of the patients are far bigger than you guys combined, and the environment's not always safe. And so, I mean, I just want to give you guys a lot of respect because I think you guys have a tough job, and I admit I don't think you guys get the appreciation you deserve. And so I want to say language matters in the same way that we may not always be using the best language. It's really important to maintain that same respect for language with patients. We do have to ask them uncomfortable things like, are you incontinent? Are you having impotence? And just asking it in a really gentle manner will probably go over better with patients. Let me skip through this. I do have one more case I'm going to run through. Is everyone tired of this back pain, or can I do one more case? Be honest. I'm okay. You guys okay? Not falling asleep on me? All right. I'm going to do one quick case. So 5 alpha 2 patient does not have difficulty breathing. They're completely alert. They did not faint. They were moving some boxes. Anyone see anything abnormal with the vital signs? Normal. No massive hemorrhage. A, B, C, D, E, totally normal. Sample history, okay, great. They had back pain in their right lower back after they started moving some boxes. And it's a shooting pain, no drug allergies. They're on Zyrtec. They have some seasonal allergies, and it started right when they were moving. You do your secondary survey. Really, there's nothing except they have a little bit of pain in the right lower back muscle with some hypertonic muscles. What do you guys think? Anything else? Probably a muscle strain, like you said. Could be some DJD, maybe a herniated disc. The point of this case is just think through the, okay, could it be this? Could, you know, just make sure we're not just excluding this person because it sounds like a simple case. Because really the diagnosis of back pain is really for us going to be a diagnosis of exclusion. We have to be extremely comfortable before we chalk it up to muscle pain. And so, again, the big takeaways from this lecture are do a good history, do a good physical, think critically, and do it systematically. Same way you guys rock when it comes to trauma and rock when it comes to cardiac stuff. But, you know, when it comes to back pain, it's a tough diagnosis because it could be a million different things. And this message goes out to not just medics and paramedics and EMTs, but anyone that touches a patient with back pain, they need to have a systematic approach. These are, again, the red flags. Any kind of trauma, age over 70, or mild trauma in age over 50, steroids, immunocompromised patients with fever, syncope, sudden onset under benign conditions, cancer, night pain, weight loss, night sweats, any infection, history of IV drug abuse, pain in the peds patients. Always got to think twice about the pediatric back pain complaints because a lot of times it's cancer and anyone with any kind of hardware in their body. These are the red flags for vital signs: hypotension, tachycardia, fever, any pulse deficits, which is really easy to check. Any signs that the patient sends a urinary retention, vocal weakness, any numbness, tingling, any new murmur, or that elusive pulsatile abdominal mass. Remember, just avoid the tunnel vision. It's easy to see. Just because 10 patients with back pain have musculoskeletal strain doesn't mean the 11th one will. Always ask the right questions, think through the differentials, and just know that annoying patients may be annoying because they have a real disease. And again, you guys are the front line. You guys set the tone. You guys can totally have a huge impact on a patient. Like I said, when you guys tell us you're nervous or you're worried, that usually prompts us to think harder and be more considerate. And so I hope that you got something out of this lecture today. Thank you, guys. Anyone have any questions? All right. Thanks, guys. Appreciate it.
Thank you, Dr. Boston. Okay, guys. Couple things I wanted to bring up. EMS Skills Days. There's a calendar up here by the sign-in sheet. If you didn't sign in, please sign in. August 19th, 20th, 21st, and 22nd. They're going to be all 4 half days, 2 afternoons, 19th and 20th, 2 mornings for the 21st and 22nd. You will end up within those skills days, of course, is filling out your skills for the year for your medic or your EMT certification, whatever level you are. You will be able to hit every one of the skills that's on there. Couple things that we've been talking about in advisory, new protocols and some changes that'll be coming out. Hopefully they will be available October 1st. We've been working on them, trying to get those together. Capnography, it needs to be done. It's required. So anytime you do an intubation, airway of any kind, you need capnography. Not everybody's not doing it. Not everybody's doing it. It's just across the board, every service, every provider, capnography needs to be done. If you do any kind of airway intervention whatsoever, please, 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 capnography. After reviewing runs for the last 4 or 5 days, there's been a trend. It's not just one, it's not just two, it's several people. If you transport a patient, there's no way in the world you can have only one set of vital signs. And this is happening all across the place. This is just, you cannot transport a patient across town, across the country, wherever you guys are at, whatever you're doing, and only have one set of vital signs. And it's happening. Trust me, I've been reading the run reports. Shane, have you seen them? That needs to stop. You can't tell me that you have a patient for 10 minutes and you can't do 2 sets of vital signs. No, always need 2 sets of vital signs. Any kind of work you do at all. Oxygen, you need to change. I don't care if the numbers don't change, you still need 2 sets of vital signs. So just some things that were recognized. Spell check is your friend. Utilize it if you can. Okay, it's not required, but it might help you on the stand. So Some people been lots and lots of subjective detail in your narratives. That's not necessary. You know, put in the narrative what's there, not what you think's there, but what is there. Anybody else have any questions? Anything else? Anybody else want to bring something up? Thanks. Really appreciate it. Have a good day.